Fixed learning module is a permanent display of teaching and learning material which students go through at their own convenience. In the respiratory module, we have two fixed learning modules, one on pleural diseases and the other one on the investigation of lung diseases. This video is to supplement the fixed learning module on investigation of lung diseases. The objective of this fixed learning module is to look at the value of the examination of the sputum, lung function testing, bronchoscopy, chest radiograph, and some other special investigations. First, let's take a look at the examination of the sputum. Macroscopical appearance is useful. We subject the sputum to other microbiological examinations like gram stain, acid-fast stain, culture, and antibiotic sensitivity testing. When malignancy is suspected, sputum cytology is invaluable. When you collect the sputum, particularly for acid-fast stains, we ask the patient to cough as the first thing early in the morning before rinsing the mouth. We take 3 such samples and send them for the examination. Sometimes macroscopical appearance gives a clue to the diagnosis, like in the mucoid sputum, in chronic bronchitis and asthma, frothy sputum, classically pink frothy sputum in pulmonary edema, purulent sputum, bronchiectasis, lung abscess, and also in the resolving phase of pneumonia. Bloodstained sputum is alarming, seen in early stages of pneumonia, bronchial malignancy, tuberculosis, bronchiectasis, and in pulmonary infarction. Let's take a look at some of the microbiological investigations now. Sputum smears are examined after staining with gram stain. This might give a clue as to what the causative organism is. Culture will help you to isolate the growth and to test for antibiotic sensitivity. If the growth is a mixed growth, it's difficult to interpret. Streptococci are gram-positive organisms in chains. Staphylococci, gram-positive cocci in clusters. Klebsiella is a gram-negative organism which is a cause of upper lobe pneumonia. And here you can see the pneumococci, gram-positive cocci in pairs. When you suspect tuberculosis on the acid-fast stain, acid and alcohol-fast bacilli are not all that easy to detect. The culture on LG medium takes a long time. There are several basic lung function tests. Peak expiratory flow rate, or the PFR, is a very useful bedside test, but spirometry, the lung volumes and diffusion capacity are not commonly done. Let's see whether you can label this diagram. I'm sure most of you are familiar with this. The subject is breathing normally, the tidal breaths, and has been asked to take a deep breath and then breathe out fully. Now here's time for you to stop the tape, hit the pause button, and try and label what 1 to 6 are. These are lung volumes and the capacities. When the music comes up, you can pause the tape. When you are ready, let's look at the answers. Number 1 is a tidal volume. Patient is breathing normally, and he has been asked to take a deep breath in and breathe out. That is a vital capacity. What remains in the lung after the vital capacity breath, that is number 3, is the residual volume. Number 4 is a functional residual capacity, that is what this is a spirometer which is used to measure the vital capacity and the FEV1. This is the tracing we have obtained from this vital graph or the spirometer. Here, the vital capacity, the maximum volume of air blown out is 2.7 liters. FEV1 is defined as the amount of air that has been expired during the first second. In this case, it is 2.5 liters. This equation is useful. So FEV1 ratio is FEV1 divided by the forced vital capacity multiplied by 100. With the value we obtain for FEV1, we can categorize lung diseases between obstructive and restrictive. In obstructive, FEV1 is low, FVC is normal, but the FEV1 ratio is less than 70%. In restrictive, both FEV1 and FVC are low, but the ratio remains over 70%. Now here's a series of exercises for you. We would like you to calculate the FEV1, FVC and the ratio, and then interpret whether it is normal or abnormal. When the music comes up, you can pause the tape and then do the exercise yourself. In this case, FEV1 is 3.1, forced vital capacity is 3.8, the ratio is 82%, and this is a normal spirometry chart. Exercise 3. FEV1 is 0.5 liters, FVC is 2.2 liters, FeV1 over FeV0 ratio is 23%. And this is an example of obstructive airway disease. Exercise 4. FeV1 is 1.8 liters, FeC 2 liters. FeV1 ratio is 90%. Here both FeV1 and FeC are low, but the ratio remains over 70%, and this is a case of restrictive airway disease. Let's take a look at the carbon monoxide diffusion capacity. This determines whether the alveolar capillary membrane is intact or not. In cases where the alveolar membrane is damaged, carbon monoxide diffusion capacity, which is a measure of the permeability, is affected. So let's take a look at these conditions and see whether carbon monoxide diffusion capacity is reduced or not. Asthma is a condition where there's a problem with the airways, therefore carbon monoxide diffusion capacity is normal, and so is the permeability of the alveolar capillary membrane. In emphysema, alveolar capillary membrane is damaged, and therefore carbon monoxide diffusion capacity is low, so is in lung fibrosis. Ankylosing spondylitis is a restrictive airway disease due to a problem of the rib cage. There's nothing wrong with the alveolar capillary membrane, and hence carbon monoxide diffusion capacity is normal. In polycythemia, because of the increased hemoglobin concentration in the blood, carbon monoxide is taken up more rapidly and more readily, and therefore carbon monoxide diffusion capacity is in fact increased. When there's bleeding into the lung also, because of the blood inside the lung alveoli, it takes up the carbon monoxide and is another cause of increased carbon monoxide diffusion capacity. Exercise 6. In these 4 conditions, you can work out whether vital capacity, total lung capacity, FeV1 ratio, and carbon monoxide diffusion capacity normal or abnormal. In case of asthma, vital capacity is normal or low, total lung capacity is high because of the air trapping, and the FeV1 ratio is low, and carbon monoxide diffusion capacity is normal. Emphysema is another cause of obstructive airway disease where there is damage to the alveolar capillary membrane. Vital capacity may be normal or low. Because of the air trapping, their lungs are expanded and total lung capacity is high. The ratio, FeV1 ratio is low, carbon monoxide diffusion capacity is also reduced. In lung fibrosis, there is a shrinking of the lung, vital capacity is hence low, total lung capacity is also low, the ratio could be normal, carbon monoxide diffusion capacity is reduced. This is a case of restrictive airway disease with alveolar capillary membrane damage. In ankylosing spondylitis, another cause of restrictive airway disease, vital capacity is low, reduced, total lung capacity also reduced, FeV1 VC ratio is more than normal, that's more than 70%, it's normal, carbon monoxide diffusion capacity also normal. This is in contrast to lung fibrosis. This is a flow volume low. This is the residual volume. Patient breathes in, this is the inspiratory limb, then breathes out fully, as fast and as full as possible. This is the expiratory limb back to the residual volume. Residual volume, inspiration to the total lung capacity, breathes out back to the residual volume. This is a case of normal flow volume loop. Number 2 is a case of asthma, where you can see the expiratory limb is markedly reduced and there's a concave appearance to that. Number 3 is an example of extrathoracic airway narrowing, where inspiration is more affected than the expiration. Radiology, one of the most useful forms of investigations in lung disease. Before we proceed, let's work out the exercise 7. I have labeled this diagram. This is a cartoon of the PA view of a chest radiograph. Let's see whether you can label this A to G. When you are ready, pause the tape, do the exercise, and then get back to the tape to look at the answers. A is trachea, B is aortic knuckle, C left main bronchus, D you could see